All right, part D is going to cover hypothalamus and pituitary glands, as well as the beginning of the thyroid system. So the hypothalamus and the pituitary glands, the pituitary gland is known as the master gland. It kind of controls everything else. It consists of the anterior and posterior pituitary. They both are linked to the hypothalamus. And it's made up of it secretes hormones that are water soluble or protein based, and they control many parts of the body. Anterior, you can see on this chart here, the adrenocorticotropic, the thyroid-stimulating, growth hormone, luteinizing hormone, prolactin, and follicle stimulating hormone. Posterior would be antidiuretic hormone and oxytocin. The reason why you know which hormone comes from which area is if there's a alteration in the amount of that hormone in a person, that would signal which part of the pituitary gland is not functioning correctly. But we will talk about one of those in particular, and that is the thyroid hormone. So the thyroid hormones play important roles throughout the human body. They aid in regulation of lipid and carbohydrate metabolism. They're essential for normal growth and development. The hypothalamus secretes thyroid-releasing hormone, TRH. Now, TRH stimulates the pituitary gland to secrete TSH, which stimulates the thyroid gland to release the hormones T3 and T4. Thyroid function is regulated through multiple levels of hormonal control. But I want you to remember TSH, T3, and T4. Thyroid's primary function is to control metabolism. And it does that by secreting T3, T4, and calcitonin. So let's look at some thyroid hormones. Now, whenever you hear thyroid, think metabolism. The thyroid function affects every system in the body. Lipid and carbohydrate metabolism, heat production, reproduction, cardiac and nervous system function. Thyroid hormones regulate the basal metabolic rate, which is the baseline speed at which cells perform their function. Basal metabolic rate is just your standard speed at which your cells function. The thyroid feedback mechanism works through the thyroid and the pituitary gland, and it's kind of a feedback loop. It says, TSH is pumped out to make more T3, T4. T3, T4 go to the brain. It says it just is a constant cycle going around. When one of those hormones is deficient or in overproduction, problems develop. What are the diagnostic tests? Well, first you're just going to take a history and physical. You want to find out everything that's going on. Because a person might come in and say, I have no energy. Well, there's a lot of reasons for that. Thyroid might be one, but only one. You'll do some lab tests. You'll look for serum TSH and also serum T3 and especially T4. TSH and T4 is used to monitor the therapeutic effects of levothyroxine, which is the standard treatment for hypothyroidism. So, person taking levothyroxine, if the TSH levels are correct, if the T4 levels are correct, you know you have a good therapeutic response. Now, TSH will be high when the defect is in the thyroid. When it's low, the defect is in the pituitary system, pituitary gland. So, hyperthyroidism. Hyperthyroidism has a greatly increased metabolism. You have excessive secretion of thyroid hormone by the thyroid gland. So there are types of hyperthyroidism. Graves' disease is the most common. It's considered an autoimmune disorder. It occurs 8 times more commonly in men than women. usually developing in between age 30 and 40, strong familial association, and a thyroid gland enlargement. If you notice that picture, it looks like their eyes are puffy or large. That's from Graves' disease. Plummer's disease is least common, onset between 40 and 50 years. A single nodule within the thyroid produces excessive amounts of thyroid hormone, which results in a suppression of activity in the gland. You can have drug-induced hypothyroid, maybe caused by iodine supplementation in clients who have been iodine deficient. It also can be caused by excessive dose of thyroid hormones. And then there's the thyroid storm. And the next slide will talk about that in greater detail. This is an acute overproduction of thyroid hormone, which may be precipitated by stress or infection, and it may cause death. These are hyperthyroid conditions. So hyperthyroid, overactive metabolism. Thyroid storm is an extreme hyperthyroid state. Fever, tachycardia, CHF, palpitations, CNS disturbances, all of those will be noticed in a thyroid storm. You'll need to probably give the person oxygen. Hypothermia, chill that person down. Digitalis, remember why we give digitalis? To slow the heart down. Diuretics, acetaminophen, antithyroid meds, and beta blockers, everything to slow that heart down. It can be caused by stress, surgery, or withdrawal of antithyroid medications. Beta-blocking agents are given to alleviate the adrenergic problems such as tachycardia, palpitations, sweating, and tremor. Antithyroid drugs are given to control thyroid secretion. If a person has hyperthyroidism, you can expect them to have insomnia, weight loss. Even though they have an increased appetite, they're going to experience weight loss. Muscle weakness and fatigue, palpitations and tachycardia again. Irritability, nervousness, insomnia, I mentioned that already. Heat intolerance, they get just overheated so easily. Excessive perspiration, diarrhea, exophthalmos, that's the bulging eyes. You could have altered menstrual flow. Irritability, I mentioned that. So hyperthyroid has a lot of symptoms that could be many other things. So we never assume that it's hyperthyroid until we do the which test? TSH and T4. That'll tell us what's going on. So let's say a person is diagnosed as hyperthyroid. What are we going to do? Well, we need to inhibit the incorporation of iodine atoms into the precursors of T3 and T4. So we're going to give medications like propylthiouracil, PTU, or methimazole, Tapazole is the brand name. Methimazole does not inhibit peripheral conversion of T4 to T3 as does PTU, but it's 10 times more potent and has a longer half-life than PTU. Prolonged use of these medications may cause a goiter. Goiter is a very enlarged thyroid. Because the increased TSH secretion and the inhibited T4 and T3 synthesis may be delayed from several days to as long as 6 to 12 weeks. The effects include a return to normal thyroid function and a weight gain, reduction in anxiety, less insomnia, and slower pulse rate. We would use these for hyperthyroidism and in preparation for a thyroidectomy or removal of the thyroid. So the thiamides, side effects, common, skin rash, GI upset, joint pain, headaches. It can be hepatotoxic, have blood issues, thrombocytopenia, agranulocytosis. So what nursing considerations we need to do? We will monitor the blood counts and the TSH level and monitor vital signs. We want to make sure that the person does not experience hyperthyroidism. We'll monitor weight every week for weight gain because of the slower metabolism. We're going to watch for signs of infection because the agranulocytosis. we're going to monitor dietary intake. We're going to try to avoid foods with high iodine content, such as soy, tofu, turnips, iodized salt, and some breads. Iodine increases the production of thyroid hormones, which is what we want to avoid. Hyperthyroid medications, such as sodium iodide. This is a radioactive isotope of iodine. The radiation destroys part or all of that thyroid. So you're actually going to take a radioactive iodine, and thyroid pulls up that iodine to kill the thyroid. It's taken up in the thyroid, and beta rays from that radioactive iodine is emitted, which destroys the thyroid cells without damaging surrounding tissue. The goal is to destroy just enough of the thyroid gland so that levels of thyroid function return to normal. It's difficult to calculate the exact dose needed to achieve the right thyroid state, though. So while a person is using this, they should not come in contact with children or pregnant women for 1 week following the administration of the drug, because the patient will be emitting small amounts of radiation. Small amounts. Enough to harm? Probably not. We're going to take a chance? No. Hypothyroidism can occur about 10 years after treatment. The last result would be a subtotal thyroidectomy, meaning removing not totally, but part of the thyroid gland. Now, hypothyroidism is the exact opposite. Primary hypothyroidism is the most common cause. It's an autoimmune disease. Surgical removal of the thyroid would also cause hypothyroidism, or aggressive treatments with anti-thyroid drugs. Hashimoto's disease is the most common cause of hypothyroidism. Goiters are not seen very often anymore. They're thyroid glands that have enlarged as a result of excessive stimulation by TSH, or they're enlarged because of decreased iodine intake. The reason why we almost never see those anymore in developed countries is iodide-treated salt. You get enough salt, enough iodine in your salt, and that keeps you from developing a goiter. But that's what a goiter looks like. Hypothyroidism, almost the exact opposite of hyperthyroidism. Fatigue and general weakness, muscle cramps, and dry skin is a big one. Weight gain, edema, dry, coarse, thinning hair, slow pulse rate. Hyperthyroid, you're intolerant of heat. Hypothyroid, you're intolerant of cold. You develop thick skin, potentially depression, and bradycardia. A decreased sense of taste and smell also is common with hypothyroidism. So, hyperthyroid, everything is speeding up. Palpitations of the heart, heat generation. Hypothyroidism, the heart's slowing down, heat generation is slowing down. So that's hypo. Hypothyroid medications, we're looking at levothyroxine, like I mentioned earlier. A brand name of that is Synthroid, but we're going to say levothyroxine because we're always going to try to work with generic names. Levothyroxine is a once-a-day dosing. It replaces, the treatment is replacement of T3 to T4 to normal levels. Thyroid preparations are given to replace what the thyroid itself cannot produce. So we achieve a euthyroid or normal thyroid level. The therapeutic window is very narrow. Overtreatment will result in hyperthyroidism. Undertreatment, hypothyroidism. Side effects, stimulation of all metabolic processes. The most serious side effects are an increase in cardiac system function, the tachycardia, the palpitations. Sometimes in the elderly we need to reduce doses. Side effects, tachycardia, palpitations, dysrhythmias, or bad rhythms, hypertension, insomnia, tremors, and headaches. Now we're going to be very careful if a person has adrenal insufficiency, if they've recently had a myocardial infarction or heart attack, if they have hyperthyroidism or a drug allergy. if they recent heart attack, imagine if a person had a recent heart attack and we give them a medication that stimulates their metabolism and speeds their heart up. You see where that would be the problem? So drug interactions, oral anticoagulants such as warfarin have an increased anticoagulant effect. Digitalis with thyroid agents have a decreased serum level. It also it decreases the serum levels of oral hypoglycemic agents, and epinephrine used with thyroid medications, levothyroxine, may induce coronary insufficiency. So we use that very carefully. So nursing considerations and patient teachings. You need to monitor vital signs carefully. The cardiac vital signs particularly. Heart rate, pulse, heart rate is pulse, blood pressure. We're looking for edema. We're looking, to see if the heart's pumping correctly. We want to give the drug same time every day. That way we can maintain that narrow therapeutic window. We do not discontinue these meds without the physician's approval or order. Too high of a dose will cause nervousness, irritability, and insomnia. You need to be careful. We're not going to try to. We're going to eat food. We're going to try to eat foods that are not high in iodine: soy, turnips, seafood, some breads. They should avoid iodized salt if they're taking anti-thyroid medications. We're going to hold thyroid medication if the apical pulse is greater than 100. And hypothyroid clients are more sensitive to CNS depressants. Come back for the next section. We're going to talk about glucocorticoids.